Welcome to the deep dive. Today we're tackling a really common topic, herpes simplex virus, HSV. We've got some revision notes here.
Yep.
And the plan is simple, really. We're just going to go through them bit by bit and pull out the absolute must-know stuff for you.
Sort of cutting through the noise.
Exactly. Making it high yield, memorable, especially if you're, say, revising or just need a quick, solid understanding.
Right. Think of it as getting the key synthesis from the source material without wading through everything. We pick out what really matters for recall.
Okay, sounds good. Let's dive in. Starting at the top. What exactly is herpes simplex virus according to these notes?
Okay, so the notes define it pretty clearly. It's a viral infection caused by one of two types, HSV1 or HSV2.
Right.
And they stress it's highly contagious, affects the skin, and mucous membranes primarily.
Okay, and these two types, HSV1 and HSV2, do they typically show up differently?
Yeah, there's a classic distinction. HSV1 is, usually linked with oral herpes, think cold sores.
Okay.
And HSV2 is more commonly the cause of genital herpes. But importantly, the notes do say there's overlap.
So it's not strictly one or the other in terms of location.
Exactly. You can get HSV1 genitally and HSV2 orally. The association is typical, but not absolute.
Got it. So moving on to how people actually get it. Etiology, causes, transmission. What do the notes say?
It's all about direct contact. Contact with someone who's infected.
Through what specifically?
Things like saliva, active skin sores or lesions, or mucosal secretions.
Yeah.
Direct person-to-person contact is key.
And is the route different for type 1 versus type 2 generally?
Yeah, the notes specify that. HSV1 transmission is mainly oral to oral,
Yeah.
kissing, sharing utensils, that kind of thing.
Right.
Whereas HSV2 is primarily spread through sexual contact.
Right. Now, here's something the notes mention that sounds quite significant. Asymptomatic shedding. What's that about?
Yes, that's crucial for understanding how HSV spreads so widely. It means the virus can be present on the skin or mucous membranes and therefore transmissible even when the infected person has absolutely no visible signs or symptoms.
Wow. So no sores, nothing obvious, but they can still pass it on.
Precisely. The virus sheds intermittently without causing symptoms. That's a major factor in transmission.
That really complicates prevention, doesn't it? So building on that, what puts someone at higher risk? What are the risk factors listed?
The notes list a few key things. Unprotected sex is a big one, obviously linked to HSV2 transmission.
Makes sense.
Having multiple sexual partners increases exposure risk.
Yeah.
Also, a weakened immune system.
Like an HIV, for instance.
Exactly, HIV is mentioned. Or other immunosuppressing conditions or treatments. These individuals are more susceptible and can have worse outbreaks.
Anything else?
Well, prior HSV infection is listed, maybe meaning infection with one type doesn't protect against the other. And of course, direct contact with someone who does have active lesions significantly increases risk.
Okay. Let's get into the biology of it. Pathophysiology. What actually happens in the body when someone gets infected?
Right. So the initial infection starts when the virus gets in, usually through those tiny breaks in the skin or mucous membranes we mentioned.
Okay.
Once inside, it invades host cells and starts replicating, making copies of itself.
And what does that replication do?
It leads to cell damage and destruction. And that's what causes the characteristic signs, those vesicles, the blisters or sores.
But it doesn't just stop there, right? The notes mention latency.
Exactly. This is key to understanding HSV.
Ah.
After that initial infection phase, the virus travels up the nerve pathways from the skin site.
Up the nerves.
Yeah, and it establishes a dormant or latent infection within nerve cells, specifically in the sensory ganglia.
So it just hides there.
Pretty much.
Right.
It hides out in the nerve cells, inactive. Trigeminal ganglion for oral, sacral ganglia for genital herpes are the common sites.
And this dormancy, it's not forever, is it? That's
That's
where outbreaks come from.
Correct. It's not eliminated. The virus can be periodically reactivated.
By what? What triggers it?
Various things mentioned in the notes. Stress, illness, fever, sunlight exposure, hormonal changes, sometimes physical trauma to the area.
And when it reactivates.
It travels back down the same nerve pathway to the original site of infection on the skin or mucosa, and that causes a recurrent outbreak.
Fascinating mechanism. Okay, so if someone comes in with symptoms, maybe blisters or sores, what else might be going on? What's in the differential diagnosis list?
Good question. The notes suggest, considering other things, varicella zoster virus is one.
Chickenpox and shingles virus.
Right. Shingles in particular can cause blisters in a specific nerve distribution, which might look similar initially. Coxsackie virus is another one.
Hand, foot, and mouth.
Yeah, that can cause oral sores. And then, more broadly, the notes say to consider other conditions causing genital or oral ulcers, things like syphilis, chancroid, or even non-infectious causes like aphthous ulcers.
Okay, good to keep those in mind. Let's shift now to how common this is. Epidemiology, specifically in the UK, as the notes mention.
Right, the UK context. The prevalence is described as high,
High meaning.
meaning a really significant chunk of the population has been infected with either HSV-1 or HSV-2, or sometimes both. Many people have antibodies.
Is one type more common for, say, genital herpes in the UK?
The notes specify that for genital herpes diagnoses in the UK, HSV-2 has traditionally been more common. But they also mention that HSV-1 is an increasingly recognized cause of new genital herpes cases.
Interesting trend. And it affects everyone.
Yes, across all ages and genders. Widespread.
All right, so let's talk about what it actually looks like, the clinical presentation, signs, and symptoms.
Okay. It usually manifests, as we said, as either oral herpes, mostly HSV-1, or genital herpes, mostly HSV-2.
And what are the classic symptoms?
The hallmark is painful or itchy blisters or vesicles, which then rupture to form shallow ulcers.
Where exactly?
For oral herpes, typically on the lips, the vermilion border, or around the mouth, sometimes inside. For genital herpes, on the penis, vulva, buttocks, thighs, or around the anus.
Are there other symptoms, maybe particularly the first time someone gets it?
Yes, the initial or primary outbreak is often more dramatic.
How so?
Besides the sores, which can be quite extensive and painful, people might get systemic symptoms. Things like fever, headache, muscle aches, fatigue, and swollen lymph nodes nearby inguinal nodes for genital, cervical nodes for oral.
Like having the flu almost.
Kinda, yeah. And the notes add that a primary oral infection, especially in kids, can be really severe, something called gingivostomatitis.
What's that involve?
Widespread painful sores and inflammation affecting the gums, the tongue, the inside of the mouth. Makes it really hard to eat or drink.
Ouch. And subsequent outbreaks, are they the same?
Generally, no. The notes mention recurrent outbreaks are typically milder.
Milder how?
Usually fewer sores, less pain, shorter duration, maybe lasting a week or so instead of 2 or 3 weeks, like a primary infection. And those systemic flu-like symptoms are usually absent or much less pronounced, often preceded by a prodrome, like tingling or itching where the sores will appear.
Right, that prodrome is a common warning sign. Okay, so how do clinicians actually confirm it's HSV? What investigations are used?
Often, the diagnosis is made clinically, just based on the appearance of the sores and the patient's history.
But if confirmation is needed,
Then lab tests come in. The notes list a few main ones. Viral culture is one.
growing the virus.
Exactly. You swab fluid from an active blister and try to grow the virus in the lab. Confirms active infection.
Downsides.
Can take days, and sensitivity decreases as lesions start to heal. Less likely to be positive on older sores.
Okay, what else?
PCR polymerase chain reaction. This looks for the virus's genetic material, its DNA.
And that's better.
It's generally much more sensitive than culture, especially on healing lesions, or even sometimes for detecting asymptomatic shedding from swabs.
Yeah.
It's faster, too. Often the preferred test now for confirming from a lesion.
Right. Any other tests mentioned?
Serological tests. These are blood tests.
What do they look for?
They detect antibodies the body makes against HSV-1 and HSV-2.
So they tell you if someone's infected.
They tell you if someone has been infected at some point in the past. They can usually distinguish between HSV-1 and HSV-2 antibodies, too.
Ah, so useful for knowing past exposure, or maybe diagnosing someone without active sores.
Exactly. But they don't reliably tell you if a current set of symptoms is due to HSV, because antibodies take time to develop and persist long-term. PCR, or culture, from the lesion confirms the active outbreak.
Okay, that distinction between testing methods is really useful. So once it's diagnosed, what's the management approach in the UK?
The management goals, according to the notes, are sort of threefold. 1, relieve symptoms during an outbreak. 2, reduce the frequency and severity of those recurrent outbreaks. And 3, prevent transmitting the virus to others.
Are there specific medications used?
Yes, the mainstay is antiviral medication. The notes list acyclovir, valacyclovir, and famciclovir.
How do they work?
They interfere with viral replication, basically stopping the virus from making more copies of itself. They don't cure it, they don't eliminate the latent virus, but they help manage the active phases.
And how are these antivirals used? The notes mention different strategies.
Right, 2 main ways. Episodic treatment.
Meaning?
You take a short course of the antiviral medication as soon as you feel an outbreak starting or when sores appear. The aim is to shorten how long the outbreak lasts and make it less severe.
And the other way?
is suppressive therapy. This involves taking an antiviral, usually acyclovir, every day, long-term,
Why would someone do that?
to significantly reduce how often outbreaks happen, or even prevent them altogether. It's often considered for people who have very frequent or particularly severe or distressing recurrences. It also significantly reduces asymptomatic shedding and therefore transmission risk.
Got it. What about things beyond medication?
Patient education is crucial. Understanding the virus, triggers, transmission, including that asymptomatic shedding. Also, counseling on safe sex practices, like using condoms consistently, though they don't offer complete protection. And just general advice on keeping the area clean and dry during an outbreak.
Do the notes specify management for the different presentations, like the gingivostomatitis or cold sores?
Yes, they do give some specifics. For that severe primary gingivostomatitis, oral acyclovir is recommended, sometimes with chlorhexidine mouthwash to help with oral hygiene.
Okay. Cold sores.
For typical cold sores, herpes labialis, topical acyclovir cream is mentioned as something people use. The notes add a point that, actually, the evidence for topical treatments being very effective is pretty limited, especially compared to oral antivirals for more troublesome cases. Oral treatment might be better if someone gets them frequently or severely.
And genital herpes.
Oral acyclovir for treating active outbreaks is standard. And as we said, for those with frequent recurrences, the notes suggest maybe 6 or more a year, then long-term suppressive therapy with oral acyclovir is often beneficial.
Right. Now, a really important area of pregnancy. What do the notes say about managing HSV then? This seems critical.
It absolutely is. The notes provide specific UK guidance here. The big concern is neonatal herpes transmission to the baby during birth, which can be very serious.
So what's the approach?
It really depends on when the mother acquires the infection and whether it's a first-time, primary, or recurrent episode.
Okay, what's the most concerning scenario?
A primary genital herpes infection acquired late in pregnancy, specifically noted as after 28 weeks gestation.
Why is that particularly bad?
Because the mother hasn't had time to develop antibodies to pass to the baby, and viral shedding at delivery is high. The risk of transmission during vaginal birth is significant.
So what's advised then?
In that specific situation, primary infection late in pregnancy, an elective cesarean section is recommended to bypass the birth canal and reduce transmission risk.
And what if it's a recurrent outbreak during pregnancy, or the mother had genital herpes before pregnancy?
If it's recurrent herpes, the risk to the baby is much lower because the mother has existing antibodies which offer the baby some protection.
So C-section not usually needed.
Generally not for recurrent herpes alone. Suppressive antiviral therapy, usually acyclovir, is often given to the mother from around 36 weeks gestation until delivery to reduce the chance of having an active outbreak or a shedding virus at the time of birth.
Okay, that primary versus recurrent distinction in pregnancy is a crucial takeaway. What about the overall long-term outlook? Prognosis?
Well, the notes state clearly it's a lifelong infection. The virus stays with you, latent in the nerves. But the prognosis is generally good with management. A key point is that for many people, the frequency and severity of recurrent outbreaks tend to decrease over time, over years.
That's somewhat reassuring. Is it always a good prognosis, though?
Not always. The notes are careful to point out that serious complications can happen,
Particularly in whom?
especially in people who are immunocompromised. Their bodies can't control the virus as well.
Right. So let's talk about those complications. What are the main ones highlighted?
Well, viral shedding itself is listed, which leads to the potential for transmission to partners. That's maybe more of a consequence than a complication to the individual, but important.
And the really serious ones.
Neonatal herpes, transmission to a newborn, is a major one. It can cause severe disease affecting the baby's brain, skin, eyes, and can be fatal or lead to long-term disability.
That underlines the importance of the pregnancy management we discussed?
Absolutely. And then for immunocompromised individuals.
Yes.
Yeah.
What can happen there?
The notes mention severe and disseminated infections,
Disseminated meaning.
meaning the virus spreads beyond the skin or genitals and can affect internal organs, the lungs, the liver, the brain, causing encephalitis, the esophagus. These can be life-threatening in someone with a very weak immune system. Other complications mentioned can include things like eye infections, keratitis if the virus gets in the eye, or sometimes meningitis.
Okay. So definitely potential for serious issues in certain situations. So, wrapping this up, our deep dive through these notes really paints a picture of HSV as, yes, a lifelong virus with that tricky latent phase,
Right, hiding out and reappearing.
but also one where understanding the virus itself, the transmission, especially that asymptomatic shedding and the different management tools available, allows for a generally good outlook for most people.
Exactly. And breaking it down section by section like this definition. Causes, path, presentation, tests, management, hopefully helps connect the dots and makes it stick in your memory better. You see the whole pathway.
And for me, what really stands out is that ability of the virus to hide in the nervous system for potentially years only to pop back up, and how managing it isn't just about the visible sores, but also about dealing with that invisible spread. It really shows the complexity, even in infections we think of as common.
Yeah, it's a clever virus in many ways.
And hopefully, making these complex topics feel a bit more manageable and clear is what this deep dive helps you with.
Absolutely.
So if you are revising for something like the MSRA exam, you might find resources over at passthemsra.com useful, and there's also freemsra.com for, well, free resources.
Worth checking out.